Welcome, welcome. And for those who come in, please have a seat. We start a bit late because there was such a queue outside. We want as many people in here as possible, and they will keep coming in. Welcome to this session Beyond the Horizon, a prelude into TAVI and complex PCI solutions. This is day one. I see a lot of friends in the audience that I haven't had the opportunity to shake hands or hug. This is day one of greetings and seeing new people, and day one of joy. We have a symposium here sponsored by Meril, and it's pretty much about their products. It's a two-part, one TAVI, one coronaries. I'm here with my spokesperson, Niels van Rooyen, who will take questions, and up there you can see how you can submit questions. And on the panel we've got José Antonio Bas, Francesco Bedoni, Joel Keffer, Ran Konowski, and Helge Möllmann, who will be there to criticize, answer questions, or ask questions. Now, the written objectives here are threefold: to explore the novel Myval OctaPro Plus THV. There will be a recorded case. I've seen it, it's great. To learn about landmark and compare TAVI updates, so evidence, and to discover the PRISM PCI Toolkit to manage complex PCI. So we've got, as I said, two parts. First, a bit about TAVI, and the second about coronaries. And we'll have a discussion and question and answer after each part, not after each talk. So, with that said, I just have introduced the team, but the speakers will be Henrik Nissen, Andreas Schäfer, Antonio Colombo, Ewald Christiansen, and Praveen Chandra, as well as Peter Andreka. That's the team, that's the objectives, and without further ado, I think it's your turn.
Thank you very much, Andreas, and indeed a great pleasure to see so many people here in this big theater. So it is. I see something moving on the screen. I'll do it myself. So it is my privilege to present the data on the landmark trial. And these are my potential conflicts of interest, and also a disclaimer from the company. So the landmark trial is a prospective randomized multicenter open label non-inferiority trial in which a total of 768 patients requiring TAVI were randomized in a one-to-one fashion to either the Myval system or a contemporary valve, being either Sapien or Evolut. The primary endpoint was a composite endpoint assessed at 30 days, but follow-up is still active and will continue up to 10 years after initiation of the trial. So, I think one very important aspect of the landmark trial is that it's really an all-comer trial, and you can see this from the inclusion and exclusion criteria. So inclusion criteria is that pretty much every patient eligible for TAVI and suitable for implantation with all three devices was also eligible for enrollment. And the only exclusion criteria were patients not willing to provide informed consent or any condition that would preclude safe participation of the patient in the study. Now, as said, the primary endpoint is a composite endpoint, and it consists of all-cause mortality, all stroke, bleeding, acute kidney injury, major vascular complications, moderate or severe PVR, and new pacemaker implantation. Now, this is the sample size calculation. So, as said, the landmark is a non-inferiority trial. The assumed event rate was 26.1% for each group. Non-inferiority margin was 10.44, which is 40% of the assumed event rate. And with a one-sided alpha of 5% and a total of 768 patients, the study was actually slightly overpowered at 93%. So not only was Landmark, or is Landmark, an all-comer study, but it's also a global study. 31 sites in 16 countries, truly all over the world. Now let's have a look at the baseline characteristics. I'm not gonna show them all in detail, but highlight a couple of them. Mean age was 80 years in both arms. The gender was very well balanced, with about 50% males as well as females. And if you look at the STS risk score, this was for the majority of patients a low risk. So the median STS risk score was actually 3%. Now, these are all the echocardiographic and CT baseline characteristics. Want to highlight two. First of all, about 1/3 of the patients actually had a small annulus, so below 430 square millimeters. And patients bicuspid valve were 6% and 7.5% respectively. Now let's go to the main outcome. As said, primary endpoint, composite endpoint at 30 days, and this occurred in 24.7% in the Myval arm as compared to 27% in the control arm. And with that 2.3% difference in favor of the Myval arm, non-inferiority was clearly met with a p-value of lower than, well, a lot of zeros and then 1. So a positive trial in that respect. Superiority was also tested, but was not met with this very small difference between the two arms. And also, if you look at all the individual components of the composite endpoint, there was really no difference between Myval and the control arm. Now, this has been published by today's chair in the Lancet in 2024. But there's also a lot of sub-studies published last year, and I want to highlight a couple of them. I think this is a very important sub-analysis. As said, the study was slightly overpowered, which enabled us to also do a comparison, individual comparison. So Myval versus Sapien, as well as Myval versus Evolut. And again, for both comparisons, non-inferiority was clearly met. And then also very important, 30 days is of course very short term, but we also now have the 1-year results available. And as you can see it here, split out per valve, so Myval, Sapien and Evolut. And as you can see also at 1 year, there's true equivalence. So with that to conclude, I think we can say that the landmark trial really established non-inferiority of the Myval series as compared to the contemporary series for early safety and effectiveness at 30 days as well as at 1 year. With that, it's actually the first positive head-to-head trial of a new platform against the contemporary standard, being Sapien and or Evolut. And patients included are really representative of a real-world setting with characteristics very similar to large registries. So with that, I think we can state that Myval is truly ready for use in routine daily practice. Thank you very much for your attention.
Thanks. Thanks. And it is the first but not the only one. So we'll
Absolutely.
ask Hendrik Nissen to talk about the other one, Compare TAVI updates.
Okay, dear colleagues, I've been given a task in 5 minutes to put you up to speed with these Compare TAVI 1 results. So I'll go through both the original study and some of the updates we have and what's to be expected. And I speak on behalf of the entire organization, of course. Compare TAVI was the... Compare TAVI 1, is it? Because we have a new TAVI Compare study. The Compare TAVI 1 was a randomization between Sapien and Myval series of transcatheter heart valves. It is the largest randomized head-to-head study of any TAVI valves as of yet. And as you will see in a short while, it's really an all-comer study. I'll try just to make it really simple in 5 minutes. So the inclusion criteria are just that they should be able to have a balloon expandable valves. Exclusion criteria are in essence none, of course, if they cannot participate for some logical reason or they're not part, but there are no hard exclusion criteria. It's non-inferiority design, very low margin of 5.3 making it clinical relevant, and we needed around 1,000 patients with this power calculation. where the composite primary endpoint is shown here of death, stroke, and moderate severe aortic regurgitation or transcatheter heart valve deterioration, definitely defined at 1 year, since it's the WAC3 criteria. And if we could prove non-inferiority, we were allowed to do some secondary analysis. So these are just the participating centers, and contrary to many other studies, these are 3 centers that we have a very high intake. So the all-comers is not just a guess, it's really all-comers, as you can see. And rather strange inclusion, which I'll just discuss with you. We start with the Myval series, but then very quickly we were not allowed to continue due to some patent issues, and we had a pause. And then we started with the OctaPro version, well, only to be halted again, just short of being completed with the 1062 planned. But even though we only met 1,031 patients, since we had a 0 dropout, we had sufficient statistical power to continue. And as you see here, we included 77% of all patients coming to one of these 3 centers. And the ones we didn't include were because and most of them were because there was an operator who decided against a balloon expandable and chose a self-expandable valve. Very few are so acute that we couldn't inform them, and even fewer are patients who declined to participate. So it's a really high inclusion rate. And of course, we used both valve and valve bicuspid and tricuspid. We used acute, subacute, and elective patients. So primary endpoint, regardless if we look at the composite endpoint in total or per protocol or complete cases, we could show that there was no difference between the 2 valve types. And this also goes to show when we put in the confidence interval, there's a good safety margin until we reach the non-inferiority margin. So we could conclude this after 1 year, that after 1 year, the 2 valve types were identical with composite endpoints of death, stroke, or regurgitation, or hemodynamic degeneration. So looking at the individual components, there was definitely a signal here on aortic regurgitation. Looking at the absolute numbers, they were not high, and if you see here, it was just a single person, 1 or 2 patients had severe AI, all the others were moderate. But there was a small signal, and the valves are not identical. There are some technical differences, balloons are different, the skirts are different, so we don't know if this is just by chance or if it's really a difference, of course. Also, pacemaker were in our study definitely a signal as being worse with the Myval series. Again, different designs, and maybe implantation was, we all do the very high implantation of the SAPIEN valve with the white line stuff, and this was maybe colored a little bit by, we weren't there yet in this valve, but there are design differences, so we have to see. We did a lot of exploratory endpoints, and I'll just focus on the ones who came out with a little bit of difference. Pacemaker 30 days, of course, different because as you'll see in the curves in a short while, all the pacemaker stuff is happening within the implantation or the first days after. Atrial fibrillation was, for some unexplained reason, a little more frequent in the Myval series, but and bleeding also, and this is only the WAC2 bleeding, and that's definitely an issue with the initial Python sheet, which wasn't perfect. But this is also interesting, or maybe especially interesting, that the patient's prosthesis mismatch was definitely to the advantage of the Myval, which also goes to show that when you see here that at all valve sizes, the affected orifice area was calculated higher for the Myval series. Only exploratory, and all the data are published in Lancet here last year. So coming to 3-year results, once again looking at this rather strange inclusion, we have used Myval at this point, and that allows us to continue looking at 3-year data only for this subpopulation treated with the original Myval. And you see here again, there's no difference in the primary composite endpoint, and at this point in time, neither on the individual components. When we looked at the event curves, as you see here, pacemaker an issue in the initial phase, and then they sort of parallel, and death and stroke, they're pretty much the same. So we could conclude after 3 years also for the original Myval series and the SAPIEN series, death, stroke, moderate, severe aortic regurgitation, or transcatheter heart valve deterioration are the same. So upcoming data, again, using these strange curves. In London Valves, we expect to present now the 5-year data of this Myval series, and for the complete cohort, the 3-year results. Thank you very much.
That should be interesting. Thank you. I have one question for both of you, actually. It's the same question, two things. How long will you follow up these patients? And if there is a benefit of having an optimal sizing strategy or tool, which we will see in a moment, when would you expect that to translate into a benefit? Just hazard a guess.
Well, for the first one, it's easy to answer. We follow them for 10 years. Second one, definitely in 3.5 years. I don't know. It's some years off.
We don't know. Somewhere in the future. Niels?
Yeah, landmarks also 10 years. Yeah, and very difficult to answer whether at all it will result in any clinical difference. I think there's still a lot to learn and say about the value of these hemodynamic values. And the side of the coin is, of course, PVR. We know that PVR over time, even moderate PVR in like 2 to 5 years can actually lead to LV deterioration. So it's not only the ppm, but also the PVR that we have to take into account. Yeah.
Thank you. And then, there's always a new iteration of the valve. There is improvement usually, and that brings us to Andreas Schäfer, who will talk about the Myval OctaPro Plus. OctaPro Plus, exactly. Andreas.
Thank you for the invitation. I would like to thank Meril for the invitation, and obviously, I will not be able to talk every part of the design properties of this special heart valve during 5 minutes. These are my potential conflicts of interest. But what I want to share with you is, at least in my opinion, the 3 most important parts of the design of this OctaPro Plus THV platform. So this is not really new to you. It's a bovine pericardium valve in a cobalt alloy frame with an internal and outer PET skirt to seal against paravalvular leakage. So far, so good. But in my opinion, the 3 most important parts is the wide range of annulus sizes which are covered by the THV platform, and especially the intermediate sizes. Secondly, it's the direct crimping of the THV on the balloon and thereby streamlining of the TAVI procedure, and the reduced THV frame shortening by changing of the upper cells of the OctaPro Plus to a chevron-like stent cell geometry. So why are intermediate sizes so important for us? I think nowadays we are all aware of the fact that under expansion of transcatheter heart valves is one of the really most important parts we have to consider when we are treating patients with TAVI. So these intermediate sizes are enabling TAVI implanters to really specify the procedure to every specific patient, and it enables TAVI implanters to choose a valve which will be fully expanded but also provides the best hemodynamics in each specific patient. And what under-expansion leads to is meanwhile documented in various studies. On the right side, we see that if the SAPIEN 3 is under-expanded, it leads to a much higher rate of structural valve deterioration, to drawbacks in hemodynamics, and sometimes, as you see on the left side, and as we saw last year, it leads to retraction of whole THV platforms, namely here the Boston Scientific platform. The second part I want to emphasize during this talk is the on-the-balloon valve crimping. It really streamlines the whole TAVI procedure. We don't have to bring the valve on the balloon in the patient itself. And what we also see is these landing zone markers, which are placed on the middle part of the balloon, which really allows for exact deployment of the valve during valve deployment. And thirdly, I also mentioned that earlier, we have these changed outflow zone, which would now have like a V-shaped chevron geometry. And this leads to an extremely reduction of THV frame shortening. And this is not only a nice optical effect during deployment, but it also leads to a really, really good predictable valve fade during deployment. And I think we are all aware of the fact that predictable valve deployment is nowadays really important for the patient, not only in terms of hemodynamics, but also in terms of reduction of pacemaker implantation rates. So Meril has a large pipeline of new techniques and of further studies which will be conducted in the near future. And for that, I will have to make a little bit of promotion for our BALANCE trial, which will start during the next month and which will compare balloon and self-expanding intra-annular transcatheter heart valves and small aortic valve annually in 13 centers in Germany, and which will hopefully give us more insights for TAVI in terms of lifetime management in those patients. Thank you for your attention, and I'm open for questions.
Can you go back one slide?
I will try to, yes.
What's the meaning of the coffees?
That is, you have to stay awake to perform all these studies.
Okay.
So we do also have one question from the audience. What are differences between OctaPro and OctaPro Plus?
So I think the main difference is really the stent frame geometry and the change of the upper stent cell frames, which are now leading to a much more less foreshortening of the valve during deployment. I think this also leads to a better prediction of deployment height.
And what are you in your center using? Do you have choice between the different Myval platforms?
We're only using OctaPro Plus due to patent issues.
Yeah.
We changed 1 year ago.
Yeah. Okay.
Also.
And this modified foreshortening has an impact on the positioning. So if you anticipate a different foreshortening of the stent platform, the positioning of the device at the beginning of the deployment will be different, or can you explain us?
It is somehow different. You really have to. So you have the central marker, this large marker at the middle of the balloon, and what you aim for is to put 70% of the marker at the aortic side and 30% of the marker on the LVOT side. And if you get the stable position, you almost every time you land like 2 to 3 millimeters with the lower part in the LVOT. It's a very stable position.
And there was also a change in the skirt that is less, is different. It's less. It's not a real skirt, but it's an envelope, like an. So the valve seems to be less heavy to insert.
True. But if this has an impact, at least in my clinical experience, I cannot say for sure because I almost exclusively implanted OctaPro Plus.
So you don't have the comparison?
No, not really.
Maybe our next speaker has, because now we're going to see that in action. Peter Andreka has a recorded case. Thank you very much, Andreas. Have you used both models, all three?
No, only Meril and OctaPro Plus, or the first generation OctaPro Plus.
Okay, so you can compare.
So, but there's a huge difference between the first generation and OctaPro Plus, and I think that the main difference is the skirt, actually, between OctaPro and OctaPro Plus. But anyway, so dear chairman, dear panel, dear friends and colleagues in the audience, I'm going to be talking about the implantation of OctaPro Plus through the new Python Neo sheet. These are my conflicts of interest, and these are the key points of this presentation. The first key point is the introduction of the new Python Neo sheet. I'm going to be talking about the so-called octa-align technique, which is commissural or coronary alignment. In this case, it will be about the commissural alignment. Some words about the ultrasound-guided femoral puncture, the LV wire pacing techniques, and some important issues about properly and precisely position the OctaPro Plus valve in the audience, in the annulus. So I'm going to be talking about the wire along the outer curve, which is very important, the no parallax during implantation, the coping for the coaxiality. It is also important, and no foreshortening. That was your question, why this valve doesn't foreshorten. The slow deployment, which I think it's also very, very, very important, and the confirmation of proper coronary alignment with fluoroscopy after the procedure. So that is the medical history of the patient. Briefly, he's an old patient with several comorbidities, and severe high flow, high gradient aortic stenosis. These are the echo images, just to prove that I'm right. And that is the multi-slice CT. And you can see that we have a 444 cubic millimeter annulus and a heart-aim decision. Because of the age and comorbidities, the heart-aim decision was very clear. Let's implant a 24.5 millimeter OctaPro Plus to this patient. And please take a look at the image, which is on the for you, the left lower side. This is the coverage of the annulus using this 24.5 millimeter OctaPro Plus valve. So you can see that it is going to be really, really pretty good. So we have the valve, what we are going to use, which height is only 20 millimeter. So we are planning to implant this valve only 3 millimeter below the annulus. So it means that we are going to have 17 millimeter of the valve above the annulus. Why shall I deal with commissural alignment if I will be above the coronaries anyway? So the thing is that, yes, we can easily access the coronaries if we are using a short valve frame balloon expandable valve, but with a good commissural alignment, we can get a much better flow pattern in the commissures. So it means that the rate of or the lifetime of the valve can be much longer if the rate of thrombosis, which can generate faster degeneration, is lower. So that's why the commissural alignment, or sometimes if it is a bicuspid anatomy, the coronary alignment is extremely crucial, even if we are working with a low frame balloon expandable valve. So what we do, so we do the right coronary commissure. This is how we place the valve inside the crocodile crimper. This is how we can get a good commissural alignment according to the clock angle. It is done by the Meril technician, so it's done by the company, but we still have to understand the procedure. And when we cross the arch, the crimper, which is towards the right coronary, it gets to the posterior wall. So this is how we can make the valve align to the commissures, and this is how the coronary orifices will be free after the implantation. So this is the procedural strategy. What you will see, it's a conscious sedation, but there's an anesthesiologist and a nurse anesthetist in the room, according to the Hungarian law. There's a left radial access for the pigtail, an echo-guided puncture of the right femoral artery, a single proglide, plus later on an angiocele, proper hemodynamics, proper peridilatation with a 20 millimeter mammoth balloon, good commissural alignment, another hemodynamics, and then confirmation of the good commissural alignment with fluoroscopy, and then later on the closure of the femorals through the new Python Neo sheet. So what is the difference between the first generation Python and the new Python Neo sheet? The dilators. The dilators are more flexible, tapered, and longer. So it is just easier to insert the sheet through the skin and the subcutaneous tissue. It has a pretty nicely visible radiopag marker. It is also important. So there's a flexible, external, stretchable sleeve, which minimizes the bleeding, which was very obvious with the first generation Python sheet. And the Python Neo, as you will see, doesn't bleed at all. And it is a new locking system with its own valve. And we can keep that locking device inside the sheet during the valve insertion and during the valve implantation. So here you can see when the valve crosses the Python Neo sheet, the entire sheet gets dilated with the valve. And please concentrate on the tip of the sheet where the marker is. When the valve comes in, I'm just going to speed it up a bit. it opens and doesn't break. That's important. So let's see what happens if you have to retrieve the valve through the sheath. As you can see, the tip doesn't break, and you can easily retrieve the valve if it is needed. So we are humans, so sometimes we make mistakes, and we realize that we have to retrieve the valve. We have to take it out of the human body. As you can see, that it's absolutely safe to do so with this new sheet. And this is the recorded case. I'm going to be narrating the case, and I will speed it up a bit. And I'm terribly sorry that you will see some trivial suggestions during the case. But I'm showing them because I think these are extremely important to have the best available results after the implant. So let's get started. So this is our institution. This is the Götzsegen National Cardiovascular Institution of Hungary. That is the largest cardiovascular center. It is dedicated exclusively to cardiovascular medicine. We do everything in pediatric cardiology and adult cardiology. And my friend and colleague Giza is standing next to me. So we've known each other for almost like 40 years. We do almost all the cases together. And then we start a case. This is the echo-guided puncture of the femoral artery. So you can see the wire. I think that nowadays it's a must to puncture the femoral artery with an echo-guided procedure. So this is how we can make sure that the vascular complication rate, even with a Python Neo sheet, will be as low as possible. So I think that nowadays it is extremely important. So what we do? So we are inserting the ProGlide. We punctured, of course, the anterior wall of the common femoral artery, avoiding the calcium. This is how the ProGlide will work better. Concentrate on the port. So we need to get constant pulsating bleeding. And then we open the stent and pull the device against the wall, and the bleeding should stop. So this is how we can place and deploy the suture. So we are pulling the device out, grab the sutures and secure them just to make sure that the sutures will be fine during the procedure. And then you will see the insertion of the sheet. The dilator is banded. We always do that. So this is how we can follow the artery. This is how we can nicely and safely torque the sheet if it is possible. So you see them here. So there's a tortuosity here. But with this band, we can torque the sheet, and we can nicely and easily get through the bands and get into the descending aorta. And here is the nicely visible marker. So the sheet is in place, and you can see that there's no bleeding. But of course, to avoid the bleeding, we still need to keep the sheet securely in place. If it comes out, it will bleed, just like all the sheet bleeds if they come out. So this is an AL1 catheter. And through this AL1, so the pigtail is in place as a non-coronary cusp from the other side, and that's an AL1 catheter. And through the AL1 catheter, it is a straight Teflon-coated wire. It is very important. We always use Teflon-coated straight wire and never a hydrophilic wire, because with a hydrophilic wire, your backup, the support is not that good, and unfortunately, you can easily perforate the ventricle. So we have the wire in the ventricle, we have the amplets in the ventricle as well, and then we exchange the amplets to a pigtail, and then we keep the pigtail. We go for a proper hemodynamics after flushing the system, and having a gradient in this case, which is approximately 60-70 millimeter mercury. So let me just speed up the video a bit. And this is, I've just stopped it. So this is the crimper. And this is the colloque angle I was talking about at the beginning of the presentation. And using the CT scan, the upper kind of enfase view of the aortic valve, we can easily identify the mid part of the right coronary cusp. And here it was at the direction of 3 o'clock and 2 minutes. And this is how we crimp the valve. The post should be towards 3 o'clock and 2 minutes, and that's what we saw here. So that's how we crimp the valve on the balloon. So we crimp the valve. So the mammoth balloon is in place. So the plan is to pre-dilate the valve with that 20 millimeter balloon. The short diameter is 21 millimeters, so it is safe to use a 20 millimeter balloon. We use a wire pacing. We use the stiff wire for pacing the left ventricle. One of the positive pulse is on the wire, and the other one is on the skin. And the output of the pacemaker goes up to 20 millivolt, and this is how we can safely pace the patient, even for a balloon expandable valve. But please be very careful. If the capture is not good, then please switch to the right ventricular pacing, especially for a balloon expandable valve. It is safer that way. So we pre-dilated the valve, and then comes the dilator of the sheath. We always pull the sheath out together with the dilator. It is just to save the vessel, not to break the sheath. If we break the sheath, it will make the hole larger, and then the vascular complication rate will go up. So here comes the valve, the dilator. So you can see how it opens with the 18 French dilator, and this is the loading device of the valve with its own valve. So you will see that we will put it into the sheath, and it will stay inside, and it will not bleed during the entire procedure. So the navigator system will go in. So it's safe, and then the valve is coming. We'll just speed up the video a bit. Here it is. Okay. So the valve. So in order to get a good commissural alignment, we need to play with the wire. If the the good coaxiality, we need to play with the wire. It is very, very important that the wire should run along the outer curve of the ascending aorta. If the coaxiality is not good enough, you can put some flex on the system to have a better coaxiality. We were discussing the positioning of the valve. The valve has a marker, as you can see. The valve has a positioning marker here. The height of the marker is 3 millimeters. So that's why you have to be very careful that you should place the bottom part of the marker on the annulus. So the distance between the tip of the valve and the bottom part of the annular marker is 3 millimeters. So if you are careful with that, you will get a very, very good result, because the valve is very stable inside the annulus, especially if the wire runs along the outer curve and the curved part is in the apex. Then you can stabilize your entire system. So the first operator is holding the navigator and the wire, and the secondary operator deploys the valve, but slowly. As you can see how slow the deployment is. And please see how stable the entire valve during the implantation, so it didn't move at all. If you're talking about the foreshortening of the valve, it is absolutely minimum. So it's a 24.5 millimeter valve. The foreshortening of a 24.5 millimeter valve is less than a millimeter. So half millimeter from above and the other half from below. And it's not even visible on the fluoroscopic field. So that's why the implantation of the valve is very safe, and the valve will stay where it is with the good hemodynamics. There is no gradient. And please take a look at the diastolic separation as well. So with a very low vascular complication rate, with a low pacemaker rate, if we are careful enough with the positioning, we can get a good hemodynamics. And if we are careful with the commissure alignment, most likely we will reach a long lifetime of this valve. And then I think that's enough from the video, because I have another that's perfect. Yes. And this is the final result of the valve, and this is for confirming the commissure alignment with fluoroscopy. So please concentrate on this part of the image. This is a cusp overlap view. So in the cusp overlap view, we separate the non-coronary cusp from the two other cusps, and the left and right cusps are in an overlapping position on the right side of the screen. So here, this is the non-coronary cusp, and this is the left one. And this is what we see from the side. So if you see two poles close to each other on the left side of the valve, and one pole on the other side, which means that from the cusp overlap view, the commissure alignment is very good. So let's confirm it from another view. So let's go to the three cusp view. So from the three cusp view, this is what we see, right? And then if you see all three cusps on a kind of a similar distance from each other, like one on the left, one on the right, and one in the middle, which means that the commissure alignment is good enough after the implantation. So I think that was it. Thank you very much for your attention, and I'm ready to take questions.
Thank you. Thank you very much. Thank you. And we'll wait for questions from the audience and from the panelists individually. I have got the first one. Explain the coaxiality. You make a big point, but what happens if it's not? What's the danger? Does this valve not align itself when the balloon goes up?
So I think it does, just to be honest to you. If the ascending aorta is not very tortuous. So if it's not very tortuous, when you come up with the balloon, it will get parallel to the ascending aorta, and most likely it will align itself towards the ascending aorta. So yes, it helps us with the coaxiality, but still, even from the beginning, I think that the coaxiality is much better if we are coaxial to the ascending aorta. So I think it's an important step.
One question more. If you do all the steps for the coaxiality, you can check only when the valve is open. You cannot.
Well, yeah, but you still can say whether the closed valve is coaxial or not. I mean, I think that's all you can do. So if at the very beginning, when the valve is still closed and it's on the balloon, it's coaxial, so most likely you will get a good coaxiality. I would suggest you to remove all the parallax from the system. I think it's another very, 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 very important step. And if you do that, I mean, you have done everything what you could for the good coaxiality, and most likely you will get a good one.
Okay.
But what would you do if you see in the closed state that you are not coaxial, but you have the angulation based on the CT with the three cusp view? Would you then change the angulation according to the not open valve, or would you rather rely on the imaging you did before?
I would definitely change the angulation. So I would just add some flex. So if my wire is along the outer curve, if I put some pressure on the wire, and when I put some pressure, since I think it's very, very important that the curved part of the wire should be sitting in the apex against the myocardium. So it means that if you put some pressure on the wire just got closer to the outer curve, but it will push your valve out of position, right? It makes sense. So then when you go in, it will get even more coaxial to the ascending aorta. But I'm talking about only millimeters. But sometimes it doesn't help, especially if the ascending aorta is very horizontal. Then you can add some more flex on the system. And if you do that, that's all you could do. Most likely it works.
Okay, that's that. You've got a question.
Yes, you know that one of the main characteristics of this device is the intermediate sizes.
Yes.
In your experience, in how many cases do you use non-regular sizes but intermediate sizes? And do you think that by using this kind of intermediate sizes, you will have an impact on the pacemaker rate?
That's a great question. So we use it quite often, actually. So what I do, I quite like numbers. So when I sit down for a couple of minutes just to decide the sizing according to the CT scan, I can decide whether I will not go higher than 5-6% oversize. And this is how we can select the valve size. So that's why I'm telling you that with a valve where you have intermediate sizes, the sizes is more precise. So you don't overstretch the annulus. I don't know whether you remember that image, what I showed you with the coverage. And of course, we overstretch the annulus with approximately like 5-6%. Overstretching increases the pacemaker rate. We know that. So we realized that like years before. So being very careful with sizing and being very careful with the implantation depth, I think it decreases the pacemaker rate. And you can end up with like 5-6% of the permanent pacemaker rate. I'm sorry.
That's an interesting point, because one of the data points that we've seen from the compare TAVI is that there is a higher pacemaker rate in the Myval and Myval OctaPro OctaCore group. Question to Ron or Francesco: do we see pacemaker rates of 22% in real practice?
With this part, our experience in pacemaker rate is around, I think, 12%.
Yeah, 12% with what valve? It's important. With which valve? Which valve type?
So Myval valve change in a different size, so probably now that so it's difficult. The mean is this one probably with the OctaPro Plus. I think you can reduce compare, for example, with the OctaCore and Myval. This is more bulky valve, you know. And our we used to implant a little bit higher, so we are doing some study about the length of the membranous septum and where is the position of left bundle branch and east bundle. So well, probably I think we can reduce with more attention and with the.
Clinical reality is different.
Different from that.
In most centers that I know. Ron, do you have any comments finally before we move to the coronary section?
Yeah, I think that the most fundamental question has not been answered, and I want to refer to the previous comment that was made on the intermediate size. Because, you know, beyond the valve structure, etc., the main differentiator here that we have intermediate size THVs, which do not exist in another balloon expandable platform. And it's a very common scenario to have intermediate size annulus And then, for example, you have the dilemma whether to overexpand 23 sapien or underexpand 26 sapien, to overexpand 26 sapien or underexpand 29 sapien. And here you have the 24.5, you have the 27.5, and I have not seen data to highlight the impact in this, I would say, gray zone scenario in order to know what is the real impact of this technology, because otherwise we end up with a non-inferiority, which means what? So how can we choose?
That was the key of my question. When do we see something? I'm aware of CT studies.
I think the intermediate range is an unanswered question, and I would like to see the data.
Yeah. There's one question from the audience.
Yeah, there's actually many questions. A lot of them have been addressed on pacemaker rate, intermediate size, etc. This one has not been addressed. It's actually, I think, a very interesting one, maybe a little bit elephant in the room like question. So what was the main driver for the rapid iterative redesign of the Myval platform from early versions to OctaPro Plus in such a short time frame? Was it primarily related to clinical outcomes, deliverability refinements, or feedback from real-world TAVI use? I think it's an interesting question. Well, I think, to my opinion, it is mainly all the legal aspects with which the introduction of this valve was surrounded, which actually forced the company to come up with new iterations, which in the end might have been sort of a blessing in disguise, because I think we have now a platform with these many different improvements and iterations that is...
I think it enables them to come up with quicker iterations, and you're right.
But I don't know if there's any
beneficial process.
Opinions on this. I think we have to move on. Okay.
But interesting point.
Last thing, I was really interested about your nice stopper cork to the Python ship, because the bleeding from the Python ship was one of the major problems, and now you realize that we can reduce a lot the bleeding from the sheath.
So what I can tell you, so I had the chance to use the Python nail sheet twice, and these two sheets didn't bleed. The Python, the older generation, they almost always bled. So that's what I can tell you.
So I think we're all waiting to get our hands on the new sheet.
So thank you very much.
Thank you very much. Thanks, Peter.
Thanks.
So I'll introduce the first. We're coming to Antonio Colombo. We're going coronary now. So completely change of topic and theme, leaving nothing behind, my experience with BRS and DCB. Antonio.
Thank you very much. Thank you to the sponsors. So this is the long-lasting questions about bioresorbable started many years ago. But I like to start with this recent analysis from the Excel trial published a few months ago on the long-term follow-up of the patient randomized in the study, and in particular to the PCI arm. This is the protocol-defined MI occurred more in the PCI versus the surgical group. But what is interesting is the outcome at 5 years. There were 23 spontaneous MI to the left main related procedure, and all of them were due to stent thrombosis and restenosis. Out of the 28 spontaneous MI related to the other vessels, 6 of them were due to stent thrombosis or restenosis, while 13 in non-stented vessel and distal to the stent. So out of 51 spontaneous MI, were quite low, considering the number of patients, I must say. 29, so more than half, were stent-related events. So I'm not going to go against stent, but I think having a stent does not necessarily protect you from an event. This is only one number of the fraction. We don't know the denominator, but still is something to think about. Then after this so-called negative statement, I like to show what I think is an anecdotal case, but really quite interesting. We go back to 2015, when we started our experience with bioresorber, and we published these 3 years outcome of this patient. At that time, we were using bioresorbable scaffold, not in simple lesion. This is a subtotal occlusion of the distal circumflex. There is a multiple disease in this obtuse marginal brain. So this, I would not call it a type A, not even a type B lesion. We implanted a 3-absorb, all generation, 140 plus strut thickness, 2 here and 1 here, with minimal overlap. And what is interesting is the 3 years follow-up. I don't think you need measurement, but you see that the lumen here is smaller than the lumen at 3 years. So here there is a clear evidence of positive remodeling. If you do the measurement, the lumen area inside the scaffold goes from 4.9 to 7.3. So this is very interesting, and we have these repeated in other patients, so this is not an anecdotal case anymore. The other advantage is the vasomotility. This is the baseline, and after nitroglycerin in a patient treated with bioresorbable scaffolds, and again, is quite visible, the change. So I think these 2 features are not replicable with the bare metal. Of course, the question is, what does it matter on the long term? I think it matters because Mother Nature made this vessel behave in this fashion. Nevertheless, when we prove these ideas, hypotheses, in a randomized study, this was published a few years ago, 924 absorbed scaffold, 145 micron thickness, compared to regular DS, the results are quite dismal. 31 patients got definite or probable stent thrombosis, 8 with a regular stent. I don't think you need statistics to dismiss these results. But here is a magnification. But look, this device compare to the synergy or to the science. You can put 4 or 5. It's like placing 5 stents, one on top of each other. So these not optimal result or bad result are not total surprise, but they are, in my view, still a surprise, because we did a work in 400 lesions published in 2017, 74% complex, with a very meticulous implantation technique, and the thrombosis rate was 1.2, with the target lesion failure at 11.6. So universal high pressure post-dilatation. I was glad. Can you do it in clinical practice? Most probably not, but that tells you that this technology is not, in my opinion, not completely dead. In the last few years, we have used the Phantom Encore, which is a tyrosine-based scaffold, thinner struts, 95, 115. Again, only hypothesis generating, but 28 patients, most of them with complex lesions, and at 18 months, there was not a single MACE, 13 patients at angiographic follow-up, and 15 patients at CT follow-up at 1 year, and no restenosis. So I would not call it conclusive but interesting results. Now we have the thin struts polymer-based bioresorbable from Meril, less than 100 micron, with visible markers on both sides, and this is goes along with the new technologies, and most probably, fortunately, may meet the expectations. Should we combine this technology with a drug-coated balloon? Yes, we did some work. We go back to 2013, where at that time we didn't have bioresorbable scaffold. We had metal stents, DS, and drug-coated balloon. Combining this technology with 45% patient diabetics, the MACE rate was at least in the positive direction, 18% versus 24, and the TLR was 5.4 versus 10. So we want to be ambitious and think to replace DS with bioresorbable scaffold and achieve a no metal approach. We are using now an hybrid approach with metal and DCB. This is a typical case where we would like to use an hybrid approach, subtotal LED with a long diffuse disease distally, not a good case even for surgery. We treated with a meta stent, with a bioresorbable, as a matter of fact, was still an absorb a few years ago, and then with a 3 drug-coated balloon distally, and this is 1 year follow-up. And this is not an anecdotal case. Mauro Gitto published a few years ago 140 patients treated with this approach. When you do an hybrid procedure, you have to accept some dissections, even near the stent. We published a few years ago this paper about spot stenting, and even if there is a dissection near the stent, if the residual lumen is sufficiently large, this dissection will not impede the flow inside the stent and cause thrombosis. The key is the residual lumen that has to be at least 70% compared to 30% of the residual lumen. I'm glad that Meril has been launching this randomized study after many years of waiting. We have to, as I said, go back to 2015. 2,250 patients, 50 sites, 26 countries. I have the privilege to be part of the steering committee. The PI is Davide Capodanno. And this trial is a very unique trial because it has no control group, are 2 experimental groups. Group experimental 1 is DCB with bioresorbable, the so-called hybrid approach, and group 2 is bioresorbable group, and very interesting study. It is not a non-inferiority, is in a quality study, and I don't know where is going to be the winner, but definitely it's the first time in my experience that I see this type of study, so I'm glad that I hope to survive to see the results. Thank you for your attention. The conclusion are the new generation BRS are safe. I think we can say that it properly implanted in registry, and ongoing trial seem to support this statement. DCB with provisional DCS implantation are effective and safe. I think now we have data to support such a statement. And combining DCB and BRS may become the new way to perform PCI. Ongoing study will evaluate these hypotheses. So what will happen? Even if this study is positive, I think there are still many unanswered questions. Metal death will prevail. There is a low cost. There is easy for most intervention how to do, predictable and safe, long-term result, not optimal but acceptable. No metal will prevail. There is a high cost. There is a learning curve needed. More robust data are needed. So no metal will prevail if there is long-term effectiveness and sustained safety. Thank you. And sorry if I...
Thank you very much, Antonio. Thank you. Thank you. Is there a question from the...
Maybe, I'm sure there's many questions, right? And also from the panel. I don't know, anyone wants to start with short question to...
When you talk about no metal, what do you think that is interventional will trust? More on PRS or drug-coating balloon?
I think you need a stent because you cannot do PCI without a mechanical support unless you are willing to go back to emergency bypass surgery. So I think to believe that the drug-coated balloon will replace or take over stents to me makes no sense. And some proximal lesions are much easier to be handled with stents. So I think the combination to me is appropriate. Can you get away from DCB and use only stents? Why not? Maybe if stents are so good, sometimes maybe more predictable. So I think this trial will be very highlighting, and I'm glad that we are doing such a work.
Because in Spain, young interventionists are trusting more in drug-coating balloon than in the absorber scaffold.
Every time something comes new, you get a lot of enthusiasm. So I think we have to wait a few years and see that the dust sets down and see if this enthusiasm, how solid it is.
Actually, in this very interesting study, you compare two experimental strategies. One is BRS with DCB, and the other one is BRS only. Why have you considered to add a conventional group, which is based on what is perceived as standard of care, which is DES or even DS with DCB?
I think your point is absolutely well taken, but the study is like this. But if I were the decision maker, I would have had a third group. I think makes sense.
Davide is leading it, so I'm sure it has got some foundation when it will be presented at the end. Shall we move on?
Okay.
Yeah, thank you very much. So, next speaker is Evald Christiansen, and he's going to talk about the ultra-thin strut desk platform, its importance, and an update on the SORT-OUT 12 trial. The floor is yours.
Thank you very much, and thank you to Meril for the invitation. I'm going to present a trial, the SORT-OUT 12 trial. I have these conflict of interest. So the evolution of desk design come from the old first generation stent. All these stents were tested in the SORT-OUT trial. We have tested all of them except the BioMine. We ended up with the Evermine, the fourth generation stent that's only 50 micron. And why is this interesting? It's interesting because ultra-thin stent struts have been associated with a significantly lower target lesion failure rate of 0.91. So we think it's obvious now to test these ultra-thin struts. The Evermine is a hybrid cell design. It has closed cells in the end and open cells in between. And it has a balloon with a low overhang that is short and abrupt shoulder to reduce the injury at the edge of the stent. It comes in very small diameters from 2.0 all the way up to 4.5 and long and short stents from 8 to 48. It's made of cobalt chromium and has an excellent radial strength and high flexibility. It's only with 4% recoil and only 1% change in length during implantation. So it has an excellent side branch access. When you take a stent and implant it with nominal pressure, you will have an opening of at least 0.95. So it's easy to rewire side branches. It's also easy to pass conventional balloon because the crossing profile of these balloons today is smaller than this. So it's easy to get into a side branch. When you further dilate the stent up to rated burst pressure, it opens to above 1 millimeter. And if you bring in a 3.5 balloon, you can expand it all the way up to 3.19. You can also see on this picture that you have the closed cells. So this is one thing you have to learn when you use this stent. You don't want these ends of the stent to cross an important side branch because these are difficult to open. We have these closed cells to prevent longitudinal compression of the stent and also achieve a good radial strength when we implant it in ostia. So the Evermind stent also demonstrated a very good radial strength compared to the 65 micron strut stents. The radial strength is not lower than 1.1 bar, and it has a better push compared to the comparator, 15% more, and the tracking is also less than the comparator. The polymer is a mix of PLGA and PLA, and it's degraded into carbon oxide and water in the body. And it has a very stable coating. It does not web, crack, or lump when we inflate the stent. So it's a very stable polymer. The sought-out trials have studied stents since 2001 in 3 high-volume centers in Western Denmark. We cover 3.2 million, and we do more than 5,000 PCIs per year. It's Aalborg, it's Aarhus, and it's Odense. And this is the steering committee. So the sought-out 12-stent trial is a randomization comparison of ultra-low strut thickness everolimus eluting stent versus the everolimus eluting stent in an all-comer population. We randomize 1:1 to the Evermind 50 versus the Steins or the Promo stent. We have 1 year, 3 year, and 5 years follow-up, and the primary endpoint is target lesion failure at 1 year. It's a composite of cardiac death, myocardial infarction, and target lesion revasc. Now we have reached more than 2,000 patients. Aalborg included 326, Odense 702, and we have included 1,047. So we will soon be able to present data on this ultra-thin strut stent.
Thank you very much. Actually, can't wait to see the data. Right? Thanks. There's new technology, and I think there are several of these ultra-thin or thinner platforms coming along, and we'll get very exciting data. I think we're entering a new phase of the third generation of absorbable scaffolds. Thank you very much. Let's come to the last talk of this session, and it's Praveen Chandra, who will give us, I think, a very practical overview about what they call the PRISM PCI and chip toolkit.
Yeah.
And I'm sure you will explain what that is.
Thank you very much. And so today I'm going to share with you this approach, which is the precision revascularization with innovation guided strategy for management of complex, a chip toolkit approach. Okay, so this is, so now the thing is that, today we have all kind of patients coming in various forms in clinical variabilities, angiographic variabilities, and of course, clinical and angiographic difficulties with which we have to treat our patients with, as we saw in the last few presentations, that there are so many ways we can treat these patients, but certainly we have to choose the right strategy for each lesion-specific strategy has to be developed. For small vessels, for bifurcations, for large vessels, aortoostal lesions, and of course, when there is a discrepancy between the diameters. Because today we are treating patients where the vessel starts with a 3.5 or 4 millimeter proximally, ends up into 2.5. So what are the options in these cases? So to deal with this situation, this is the toolkit you need to have, and this is the Meril's chip toolkit, which has various components. And for example, starting with the high-risk PCI, for MCS support, we have the Myval, which is a mechanical circulatory support device, which can be used in high-risk patients, especially when there is hemodynamic instability. And then, of course, left main and bifurcation lesions, where we need to have a stent which has good expansibility and has some tapering effects also, which we will see in that case, which I'm going to share with you. Debulking and calcium management is again very, very important, almost required in about 50% of the cases, which most busy labs where the complex cases are being done use. And here we have the cutting balloon, which is known as the Cutena, the Mason C, which is the IVL lithotripsy balloon, and Reform Pro, which is the atherectomy system, which has been developed to deal with this calcium management. And because calcium also needs different kind of approaches to be treated with. Then in ISR de novo bifurcation lesions, we have these, the drug-eluting balloon, the stents, as was already presented here, with approach to have access to these side branches. Then for softer lesions, or even for de novo lesions in various situations, we have the BRS, which Dr. Colombo also showed that there are, this is a possibility which can be done in many, many patients. Then in multivessel disease, of course, using different stent platforms and different stent iterations like Meril, Evermine 50, Biomime DS, these are the ones which we can choose for each of these particular lesions. Then, of course, for the complex hybrid PCI, for CTO, again, we have various other, extension catheters and exchange catheters which are available. And to support that, we have IVUS and OCT also, which is today's requirement in almost, I must say, 100% cases today. Because if you are treating a complex lesion, if you are treating any lesion, for example, for any patient, we need to have an accurate outcome, precise outcome, and we need to have physiology and imaging both in many patients, and of course imaging for almost every patient, be it IVUS or OCT. So these are the various devices which are, as I was already mentioning to you, which are available and which should be available in every cath lab. The toolkit for treating complex lesions, and of course, including the closure devices. So let me take you quickly through a case. There is a 60-year-old patient who comes to us in a very low ejection fraction, recent MI, high troponins, and of course has been thrombolized outside. Look at the angiogram, extremely bad disease, and the LAD is again, the culprit here, but very diffusely diseased, right from the left main going up to the tip of this LAD. The circumflex, as you saw already, is very diffusely diseased, probably not to be intervened at this time. And the RCA is also occluded from the very beginning. And again, doesn't look like that, we should approach this vessel right now. So the plan was to treat this patient, and initially the patient was very sick with the lactates of 9.4, which was stabilized initially with a balloon pump, and of course 2 inotropic or 3 drugs were given initially with ventilation. The patient stabilized, his lactates improved to 1.34, and he started making some urine. So we said, okay, this probably is the right window, sweet spot where we can start thinking about the intervention. Of course, in this case, the intervention has to be assisted. And in this case, we decided to take the Myval 4.0, which is a MCS, microaxial pump. And you can see that we can achieve flow rates up to 3.7 to 4 liters per minute with this device. And it is also percutaneous. So this is what you can see here. This is actually, the video is running fast. The patient is not in tachycardia. So this is the device which is there inside through, again, the same 14 French sheath. And once that starts operational, and of course there is a PA pressure monitoring, which we do in every case where we do mechanical circulatory support. The angiogram was done with the guiding catheter, and then we initiated these 2 devices. It is on the same system that we have the IVUS and the OCT. So this is the same system which gives the images side by side for the imaging in these patients. So imaging is certainly a requirement when we are treating complex patients like this. So This is the, the kind of images which we can see, and this is the IVUS which was done from the LED to the left main, and you can see so much of calcification. And the image quality this is a 50 megahertz catheter. This is the mid part of the LED, the ostium, and also the left main, LED left main. You can see that the ring of calcium is being seen over here. So certainly a calcified lesion. So here we thought that probably we'll predilate with the 2NC, but we see that the lesion, it cannot be crossed beyond this with distally. So we took a rota here. We did the rota to the entire length of this, going up to the distal segment, and then we post-dilated it with the Mason IVL, which is a 2.5 into 12, and here sequential dilatations were done with the intravascular lithotripsy, which is the Mason catheter, and this also is a 12 millimeter balloon, and here the markers are, as you can see, at 4 millimeters from the distal and the proximal markers, the emitters actually. So it gives 80 pulses, and the balloon sizes, we could have gone a little bit higher also, but we decided since we have to go distally first, so we'll use a 2.5, and you can use the same balloon going up proximally. If required, we can take another balloon, 3 millimeters if required. But following this, we thought that in the proximal segment, we have given shocks, so we can do a cutting balloon, use the Cutana. This is the Cutana balloon which was used in this case with these blades, you can easily, and followed by the stents, which was the Meril stent. So here you can see that the Mason IVL is, after it is being done, once the vessel preparation was over, then we did the Cutana cutting balloon, and followed by that we put stents from the distal up to the proximal, and in the proximal segment we took the morph stent, which is a long tapered stent. So here he took a 3.5 into 50 millimeter stent, which is tapered from 3.5 to 3 distal segment. Okay, so once that stent was done distally, again, we recrossed and put the stent, distal segment also, which was the biomime stent, and this is followed by post-dilatation from the distal to the proximal using the Meril NC balloons, which are ultra high pressure, which went up to 40 atmospheres. And with this, we were able to completely treat this LED, and now you see the final result. Again, the videos are not behaving well, but certainly you can see that it was fine. The branches were fine. There was no occlusion of the side branches. And this is the star beam OCT which was done. As you can see, the images look quite beautiful, and the stent is well expanded, well opposed, and the lesion was well done. So with this, if you have all the devices in the lab, and if you are ready to take up patients like this, we need to have them supported using MCS support. And of course, now it is very clear that using prophylactic MCS is better than doing at the time of compromise to these patients. And hybrid strategy of calcium modification, where we use 3 technologies all together in the same time, rota followed by IVL, Mason IVL, and the Cutana balloon for cutting, and then followed by stent delivery in a difficult situation like this. So with this, I will stop here. Thank you very much for kind attention.
Well, it's fascinating. I mean, we have so many tools, and some of them we always say or discuss there is no evidence. But then again, experienced practitioners will tell us, well, I won't do it without that, because they can see the difference, feel the difference. Where would you position imaging in this context? Do you need imaging for complex cases, or is it merely an accessory?
I think today we have come to a situation where imaging is absolutely 100% necessary, and even for a simple case, imaging is done in my cath lab, because it leads to 2 very important things. One, that whosoever does the case does it the same way. If I do a case, or if my fellow does the case, it is the same way. He measures the same things. He uses the same lengths, same diameters of the stents. It is not dependent upon the experience alone. So, which means it is standardizing the way we are treating patients today. And the data is also very positive. When imaging is used, it leads to better outcomes.
Depends on which data you look at.
Yeah, of course. Yeah, but still, standardization is something which I believe in. Like if there is a primary angioplasty which is done in my cath lab and at 1 o'clock in the night, still he will do a IVUS imaging. Because if every case is done like that, the cath lab knows it, every person knows how it is done. So it is that apprehension of how to activate the IVUS machine, how to get the IVUS catheter inside, goes away.
Let's get a final comment from each panelist. Ron, do you use all these tools in your lab?
Actually, yes. You need a toolkit in order to do such complex interventions. So you need to deal with calcium, and you need to deal with bifurcation, and you need to deal with mechanical support. So without a comprehensive tool, it's becoming very difficult and even dangerous.
Jessica?
Oh, it's an incredible toolkit that you have from Meril in India. Probably it's not yet available in Europe. Everything, but I'm asking if even a rotablator was from Meril or so.
No.
But it's a very, very, very nice case, well done, and it's very important to have the experience and first of all, it's really important to stabilize the patient with the support, the circulation support. This is really the main mandatory before to start working so hard way to the coronary.
Jose?
It's amazing the number of tools. We can use it, but only in selected cases, very young patients with so severe disease. But usually it's very, very, very impressive the number of tools. But it's very, very good result. Congratulations.
It's an impressive number of tools, and I wish I could use all of these tools in a single case like we just saw, but usually we have only to decide for one or the other tool in a given case. But nonetheless, every tool is important somehow.
I agree. So it's really impressive portfolio. I am specifically interested by your ultra-thin coronary stents. Do you think that ultra-thin struts would have an impact on the short dual antiplatelet therapy? It may be interesting in high bleeding risk patients, for example. Do you have an experience with only 2 weeks, 1 month DAPT after ultra-thin struts coronary stenting?
Yes. So ultra-thin struts, as we have seen the data also in the discussions and the experience, that with this, the need for long-term DAPT has come down dramatically. And the routine, which was earlier 1 year, has come to 6 months. And for cases where the stents are not so lengthy, like this case, in this case, I will say it will be at least 6 months, if possible. Otherwise, definitely 3 months.
Niels, questions from the audience?
No, a lot of compliments that these were all excellent presentations. But I think everybody was overwhelmed by the high quality of all the presentations.
So you wrap it up.
Yeah, I think I did. I think there was even a slide for that prepared. But if not, well, I think we can split the session in two. So part one on TAVI, and I think the technology that we've seen is amazing. It's iterative. It's constantly improving, and most importantly, we have 2 solid randomized controlled trials. So with it, I think we have great technology that has also proven to be effective in a randomized trial and thereby is actually ready to use in your routine practice. Part 2, a little bit different story, well, different entity, of course, coronary arteries, and much more on the the development part. So fantastic, fascinating new technologies. For which I do think we need more evidence, because in the end that's how we're going to shape guidelines and that's how we want to treat our patients. But again, very impressive presentations, and with that I would like to give the word back to you as our chair.
Well, with that I close the session. Thank you very much. Well said. Thank you.